Hi, my name is Dobbin Chow. I'm the program director at the University of Maryland Medical Center Midtown Campus Internal Medicine program. I want to welcome you. I want to thank you for your interest in our program. And I'm going to share with you um, information, a lot of information about our program, about our hospital, about our city. And in the past, this is, frankly speaking, it's taken a little bit of time. So uh, sit back, get a cup of coffee, put your feet up, um, buckle yourself in. Hopefully, you'll enjoy this video. Our attempt is to try to answer some of the questions, many of the questions that applicants have asked in the past um, uh, when they come to interview with us. Okay, so let's go ahead and start. Um, so we're located here in Baltimore, and this star is the location of our hospital on a map. It looks like for all the world, we're in the middle of Baltimore. It looks for all the world like we're at the confluence of these highways. There's a highway 95, which goes north to Philadelphia. 95 south goes down towards Washington, D.C. Route 83 goes up to Harrisburg, Pennsylvania. It looks like we're right at the intersection of these highways. This area that we're located in, however, is called Midtown and not downtown. The downtown region is about a mile away from where we are. The Midtown area, which is pictured here, here's our hospital here in the left lower corner. The Interstate 83 is this big highway that's pictured here in orange. And these blue dots are apartment buildings where residents have typically lived. These are in this area of town called Midtown. It's a popular area. There's three colleges in that region. There's a University of Maryland Baltimore campus, which is a commuter school. There's the University of Maryland Law School, University of Baltimore Law School, and then there's the a art school which is located just north of our hospital in this region here. It's one of the oldest art schools in the country. It's very well established and certainly brings a certain culture to the Midtown area. Now, residents have lived in these apartment buildings, which are within walking distance of the hospital. However, people can also commute to the hospital. There's a surface trolley called the light rail. It runs north-south. The northmost station is in a suburb called Hunt Valley. The southern point of the light rail is right at the airport, Baltimore Washington Airport. And so the light rail stop is 1 block away from the hospital here. There's also one subway line, and they call it the Metro. It originates in the west in a suburb called Owings Mills, and then the eastmost terminal station is right at Johns Hopkins Hospital, and the Metro stop is 1 block away from our hospital. So people can commute to the hospital by public transportation, or they can live nearby. This is the downtown area of Baltimore. It's dominated by this body of water called the Inner Harbor. Over here on the far left is the National Aquarium, and then there's areas for concerts and a lot of restaurants and hotels and a lot of distractions from the resident studies down here in this Inner Harbor area. And here's another picture of the Inner Harbor. Here's a picture of 2 of our residents on a there's a boat cruise that goes into the inner harbor. Okay, now this area of Midtown is known for the arts. There's a picture of the Walters Art Museum, which is located about 3 blocks away from us. This is the Meyerhoff Symphony Hall, which is located just to the north of us. It's a wonderful venue for music. This is the inside of the Meyerhoff. Every year there's a huge art festival in our region called Artscape. It's supposed to be the country's largest art festival. It's it was for many, many years. It was the middle of summer and it was really hot. And then they've recently tried to move it to the fall. I think that's been good because the weather has been more accommodating. It's really quite a scene. They close down all the roads in our area. People come from all over the region to attend. It's a 3 or 4 day festival, and I told one of my friends I'm coming to this hospital to work, and they said, "Oh, great! I finally have parking for Art Fest." These are the kind of friends that I have. MICA is Maryland Institute College for Art. As I mentioned, is a well-established art school. Lyric Performing Arts Center is also, it's about 2.5 blocks to the north of us. So a lot of activities related to the arts in our region. I try to focus our resident interest and evening activities on this venue, which is the School of Medicine Library. It's a comprehensive library for the health sciences that's located on the University of Maryland campus. Residents have access to it. It's open late. It's not been an easy sell. So let me now give you some background information about this hospital. I think it's worth going through to get you a sense of the history of how we came to be what we are, and it might give you a sense for the future vision. So this hospital was formerly known as Maryland General Hospital. It's been here for about 130 years now at the same site, and it was proud to serve this community. It was a private, non-profit community hospital, and the community at the time was a diverse community. People associated with the arts lived in this region. There's a community to the north of us called Bolton Hill. It's a very nice neighborhood. There's the art school, as I mentioned. There's students who attend the various colleges and universities nearby. Now, to the west of us are communities of populations that have been over the years been underserved and suffer from the challenges of socioeconomics here in Baltimore. And so it's a diverse community, and this hospital has been proud to serve these communities over the years. Then in the 1980s was a difficult time for hospitals that were in the city. This is a social economic phenomenon. People were leaving the cities and moving out to the suburbs. Flight to the suburbs, tremendous growth of the suburbs, and this occurred at all the major cities around the country, and it was definitely true here in Baltimore. People were leaving the city, moving out to the suburbs. So the hospital, the board said, "Gee, why don't we move out to the suburbs?" There was a nice suburb in the north, didn't have a hospital. It was booming, growing. So the hospital purchased land. They drafted up architectural plans to build a new hospital there. I've seen those plans. They're so detailed. You can see where the light sockets were going to go in each of the rooms. And for all the world, they were going to move. But at the last minute, the governor of Maryland came here. The mayor of Baltimore came. The state legislators knocked on the door, and they asked the hospital to please stay, and the hospital realized that we have deep roots here, we have commitment to these communities, we have service obligation to these patients, so they decided to stay. And so the hospital did, and it struggled along. Why is that? Because in about 1984, 1983, Medicare changed its reimbursement paradigm. Up until then, if whatever care you rendered to a patient, you sent the bill to Medicare, Medicare paid the bill, and that's how business was done. Then in 1983, they transformed to a DRG reimbursement system. What this means is that you get paid for a diagnosis. If you admitted a patient to the hospital with heart failure, you get paid one sum, and whether you kept the patient in the hospital for a week or you kept in the hospital for 2 days, you only get that one sum. So this was a radical change that hospitals all over the country grappled with, and it was true of this hospital. It definitely affected the bottom line of most hospitals around the country. Then in the 1990s, things did not get easier. In the 1990s, in 1992, President Clinton took office, and he tried to pass a healthcare reform bill. Now, it didn't pass, but his bill actually laid the groundwork for President Obama's bill. But President Clinton was able to enact legislature that supported the growth of HMOs. These are health maintenance organizations. Tremendous growth of HMOs in the 1990s, and what was that all about? So an HMO would they would enlist tens of thousands of patients, and then they would go to a hospital and they would say, hey, here's our contract. This is what we're going to pay you if one of our patients gets admitted to your hospital. And the hospital would say, whoa, that's not that we can't do business with those kinds of rates. And then the HMO say, okay, thank you very much. We're going to go to this other hospital down the street. And so because hospitals did not want to get shut out of these contracts, they signed these adverse contracts, and many hospitals went in the red. Some hospitals closed, and that was true here in Baltimore. Now, this phenomenon really affected the cities. Out in the rural areas, it didn't really occur because there wasn't a hospital down the street that the HMO could go use as leverage. The hospitals in the rural areas are spread apart. So what did the hospitals in the cities respond? How do they deal with this? So they merged and consolidated. So in Philadelphia, for example, there was at the beginning of that decade, I think 21 different independent hospitals. At the end of the decade, there were 3 hospital systems. There was the Penn system, the Jefferson system, the Temple Allegheny system. Same thing happened in Boston. The Mass General merged with the Brigham. Hey, up until then, people from those 2 hospitals, they won't be caught dead in the same room. Now they're part of one large medical system. Same thing happened in New York, and it's still happening in New York City. It's every day. It seems like there's a different merger or change, and it's hard to keep track of the players in New York City. But why do they do this? Because so, for example, if a HMO went to University of Pennsylvania, which is located in West Philadelphia, and said, "Hey, this is the contract we want you to sign." And Penn said, "No, we're not going to sign that bill." And and uh, and if they don't sign the bill, then all of a sudden, all the hospitals in the West Philadelphia area are not going to accept those patients. Then what is the HMO going to do when their patients need to be hospitalized and those patients happen to live in those areas? So then the HMO needed to negotiate with these large hospital systems, and that's how these hospital systems came to be. So here in Baltimore, University of Maryland created a system. Johns Hopkins created a system. Sinai Hospital created a system called LifeBridge. And so these systems developed leverage, developed negotiating power, and was able to become financially sustainable. So University of Maryland, now let me say a word about that. So University of Maryland is owned by the state, and they've been here in Baltimore for over 200 and almost over 200 years. What happened was when the people first began to populate the state of Maryland, the state said, "Gee, we need a hospital to take care of patients when they became sick." So they created the University of Maryland Medical Center, and then they created the University of Maryland School of Medicine right next to the medical center because they needed doctors to help take care of all the people who lived in the state and needed medical care. Now, over time, people moved away from Baltimore to populate the entire state. And so now there's 13 hospitals in this system, and they're located in strategic parts of the state in order to provide hospital care to people who lived throughout the state. So if you go north on Route 95, you'll hit a hospital called Upper Chesapeake Hospital, about 45 minutes north of Baltimore, and that's part of University of Maryland. If you go down to the south, there's a hospital. Well, there's a hospital near the airport called Baltimore Washington Medical Center. If in the suburb of Towson, there's the University of Maryland St. Joseph Medical Center. If you go 3 hours due east, you'll fall in the ocean. But if you go about 2.5 hours, you'll be on this region called the Eastern Shore, and the Shore Regional Hospital is now they built a new hospital there, and that's part of University of Maryland. Down by D.C., there was this is still in the state of Maryland in Prince George's County. They built a new hospital, and it's called Capital Region University of Maryland Capital Region Hospital, and it services the area east of Washington D.C. So altogether, there's 13 hospitals in this big system, and all these hospitals, if they need to get to find tertiary care for their patients, then those patients get sent to the University of Maryland Medical Center, which is located downtown. So downtown is a large tertiary referral center, and they will help manage patients from all over the state who need tertiary care. And you'll say, well, that's all nice. What's up with this hospital? This hospital is located less than a mile away from the big house from the University of Maryland Medical Center. So why did the state decide to purchase this hospital? Well, the downtown hospital, it's been in the same location all these years, over 200 years, and it's located in a downtown location. But like all medical centers, it wants to grow and expand, but it has difficulty doing so because of its downtown location. Hey, the property is expensive in the city environment. So when the state purchased this hospital, the University of Maryland Medical Center began to offload clinical services up to this site so it can grow and expand. And so what happened was the diabetes clinic was all moved up here. Endocrine clinic was moved here. The infectious disease clinic was moved up to this site. Pulmonary clinics were moved up to this site. So by offloading these clinical services to this site, the downtown site can continue to grow and expand. And it needs to grow and expand. For example, shock trauma started out as 4 beds in the ICU. Now it's a hospital unto itself. But the state had to purchase that city block that adjacent to the hospital that shock trauma now sits on. They tore down the building that was there. They built this brand new building, and it has its own ICUs. It has its own ORs. Has a auditorium on the first floor. Has a landing pad on the roof where helicopters can land, and they can get the patients directly to the OR if they need urgent surgery. So shock trauma is it was I think it was the first such center in the country, and established the precedent for centralized trauma care for a state. The School of Medicine also wanted to grow. When I first came here 10 years ago, there was this big hole in the ground next to the medical school, and what they were doing was they were building the foundation for this large research building. It cost over $130 million, 27 stories. It's built now. It's working. They're busy. It's a wonderful facility. It's helped attract faculty from all over the country to come join the faculty here at University of Maryland and get involved in basic science research. But again, that was an expensive undertaking, but it was something that the medical school prioritized. In 2015, the boards of the 2 hospitals, Midtown and Downtown, and the CEO position merged into one board, one CEO. It's basically one institution with 2 campuses, and that's become our model. Meanwhile, here at the Midtown campus, there's been unprecedented growth due to our relationship from the downtown campus and patients and services being sent up here from downtown. We serve about 130,000 patients annually. That's both inpatient and outpatient. They renovated the OR in 2010. And then about 5 years later, they added a 9th OR room just because there were the number of surgeries was growing. It cost $1 million to put in one OR. I think it's the music system. They renovated the ICU, and our ICU is staffed by the pulmonary critical care faculty from the downtown campus. So how did that happen? Well, we have about 50 pulmonary critical care faculty at the School of Medicine. Now, they could have said to each of them, hey, everyone does 1 week a year at the Midtown ICU, we'll get it covered. Thankfully, they didn't do that. They identified about 5 to 6 of pulmonary critical care faculty, and they're the ones who staff our ICU. They do 1 week at a time as the ICU attending, and they come to know our residents. They come to know our institution. They come to know our policies. They know the nurses, and they become the mentors and teachers of our residents. especially those who are interested in pulmonary critical care, and they help guide them in terms of other electives to take, research projects to pursue, and help mentor them in their help mature that interest. The new sleep lab was the inpatient sleep lab was moved to our hospital. It's on the 7th floor, and the sleep center, the outpatient sleep center, is also moved up here. A pulmonary rehab unit was moved here. This is a unique unit. These are patients who are pretty sick. Most of them are ventilator dependent, and they're getting weaned from the ventilator, but it's a prolonged weaning process. We have 22 beds on this rehab unit. Our residents don't rotate there because it's a rehab unit. It's not a internal medicine unit. However, these patients are very sick, and when they decompensate, they just get moved directly to our ICU. In 2018, they renovated the inpatient psychiatry unit here. There's 36 beds. It's a state-of-the-art unit. I don't know a whole lot about psychiatry, but apparently patients in the psychiatry units, they try to hurt themselves, and so there's the equipment and the furniture and everything about that unit is all about so the patients cannot harm themselves. People from around the country come and visit our psych unit. And then in 2021, we built this new ambulatory tower. It's 10 stories. It's a very impressive building. And the purpose of this tower is to provide clinics for patients in our region so that they could get the ambulatory care that they need. And so what's happened over the past 10, 15 years that we've transformed into a mature academic medical center with 2 campuses. Here's a picture of the ambulatory center. It's right across the street from the main hospital. And there's so endocrine clinic is on the 8th floor, GI clinic is on the 9th floor, cardiology is on the 9th floor, ID is on the 7th floor, nephrology is on the 8th floor, ophthalmology clinic is on the 7th floor, GYN is on the 10th floor, along with primary care. So the resident clinic is on the 10th floor, and it's a wonderful facility because patients can go to see multiple specialists on the same day, all in the same building. And the emphasis, the priority is on chronic disease management, meaning managing, for example, diabetes, and you'll be able to see an endocrinologist, a nephrologist, an ophthalmologist, podiatrist, all in the same building. Now, pictured in the corner here is Dr. Mohan Santa. Mohan Santa is the CEO of the entire University of Maryland medical system, all 13 hospitals, and he's a wonderful leader. He's a radiation oncologist by background, and he said that the integration of our 2 campuses provides important opportunities to be more efficient and provide the best care for our patients. And we will prioritize the role that we play as an anchor institution in the West Baltimore community, whether it's the community hospital feel of our Midtown campus or the ICU care focus of the university campus. We are providing programs and services that improves the lives of our community. And so that's the vision, and we try to live that vision that we here at Midtown we feel like we have a responsibility for the patients in our community, for the general welfare of our community, and the downtown is more of a tertiary referral center. A lot of critical care goes on there, and they provide tertiary care for all the citizens in the entire state. Now, the program goals and mission. So our program is to allow each resident to fulfill and create his or her own professional goals. Our hospital is a clinical learning environment, and we feel that it is characterized by collegiality, engagement, and a passion for scientific inquiry. Our goal is that residents teach and support each other, that it's a supportive environment for all, and that we all practice high-quality, evidence-based care delivered in a compassionate and professional manner. Now, let me introduce you to the program leadership. And I think it'll also give you a sense for how the faculty go back and forth between the two institutions. Okay. So Harsh Patel is the associate program director. Here's Harsh, and he's responsible for the inpatient curriculum. He's a hospitalist. He 100% works at Midtown. He's a graduate of the Midtown Internal Medicine program. Jeff Gerbino is an associate program director. He's in charge of the ambulatory clinic. He's in charge of the resident practice. And here's a picture of Jeff. And if when you go to the clinic, you'll meet him, you'll work with him. Dr. Malik, she's the director of endocrinology. She's a DIO. DIO means designated institutional official. Every teaching hospital is a DIO, and they're responsible for making sure that the institution provides the resources that residency programs need in order to succeed. So they follow the ACGME guidelines for institutions. So here's I'm going to go through each of the divisions and give you a sense for the faculty there. So division director of cardiology is Dr. Reyes Haq, and he's 100% based here at Midtown. He sees patients in the cardiology clinic. He also does consults in the hospital. So he's 100% here. Avelino Vercelles, on the other hand, he's director of pulmonary critical care. He spends part of his time at the VA hospital, and then much of his time here. Why is that? Because he has a research lab at the VA that he's responsible for. So he goes back and forth between the two campuses. There's a shuttle bus that goes back and forth. He goes to his clinic, which is located here on this campus, and then sometimes he's the attending in our ICU for a week at a time, and he also participates on various committees of our hospital. So he runs back and forth between the two campuses. Dr. Onder is director of nephrology, and she's 95% of the time she's based here at Midtown. Her clinic is here. She's director of the nephrology clinic. She also does consults on our nephrology consult service. They change. They do a week at a time. So each week it's a different nephrologist on the service. But she's definitely here more often than not. Occasionally she'll do weeks on the consult service at the downtown campus. But for the most part, she's here at Midtown. Now, Jenny Law is the director of the hematology oncology curriculum. She's 100% based downtown. And why is that? Because the University of Maryland Cancer Center is located downtown. Now, in your third year, you will go to the Cancer Center. You do a month-long rotation there. You work with Jenny. I think it's a nice, an excellent rotation. Jenny also is responsible for setting up monthly lectures on hematology oncology for our didactic noon conference curriculum. Dr. Ekta Gupta is a director of gastroenterology. She's new here. She's been here less than a year, and boy, she's terrific. She has so much enthusiasm, so much passion. Loves teaching residents. She's got 3 or 4 of the residents already involved in research projects. She's a whirlwind. We're very happy to have her here. She came over here from Hopkins less than a year ago. Pat Ruscavage, he's director of infectious diseases, and he sees patients in the ID clinic over in the tower. He also rotates on the inpatient consult service for a week at a time. And again, there's a rotation of them, but you'll see Pat around. He's also runs various infectious disease committees here at our hospital. Oops, sorry for that. That's a little out of order. Endocrinology, Kasif Munir is director of oncology, and he serves as a mentor for our residents who's interested in endocrinology. Dr. McDashie is director of rheumatology, and geriatrics is a rotation that's Jacob Blumenthal. Geriatrics is a rotation that's based at the VA. All third-year residents rotate at the VA in geriatrics with Jacob Blumenthal, and it's based at the VA. He's a wonderful teacher, and his reputation. He tries to encourage all of our residents to go into geriatrics. So this is Sarah Lee. She was a little bit premature in her appearance on our slide here. I guess she's eager. But Sarah is the director of our emergency medicine curriculum. All interns do a month of emergency medicine, and Sarah runs that rotation. It's very well organized. They have lectures every Wednesday morning. They rotate with different preceptors in the ED, and they do different. They have different shifts. Some shifts in the morning, some shifts in the evening, some shifts in the daytime, and then there's various procedures that they try to get the residents signed off on, and they try to get the residents to see a range of different pathologies. So it's a well-organized rotation, and residents have liked it. Okay. I don't know who these crazy people are. All right. So transitioning to the call schedule. So we have 3 medicine ward teams. On 2 of the teams, it's 1 resident, 2 interns. On 1 of the teams, it's 1 resident, 1 intern. On that particular team, it's called the intermediate care unit. These patients are a little bit sicker than the other ward teams. These patients are not quite sick enough for the ICU, but they're too sick for the regular medical wards. Then there's 2 medical students per team. Now we have a night float system. The night float works from 7 p.m. to 7 a.m. And then the ward teams sign out each day about 4 o'clock to the long call team. And then the long call team then signs out to night float. Hope that's not too confusing. Now the teams rotate being on long call every 3 days. So long call means that you're here until 7 p.m. And then if you're not a long call, then usually sign out to the long call team between 4 and 5. So here's the mock-up of the 3 different teams. The teams will accept admissions in a serial fashion, except the orange team. They only take patients who meet a certain criteria, meaning that they're a little bit more critical than the usual gold or purple team patient, but they're not sick enough for the ICU. There's a cap of 16 patients on the purple and gold team, and a cap of 7 patients on the orange team. Now the ACGME cap is, and this is this is true all over the country, is 20 patients for teams that have 1 resident, 2 interns. So the cap on the purple and gold team could be, and it was 20 patients, but we were never really at 20 patients. We were always hovering around 13, 14, never really reached 20. It was very rare. If a resident ever hit 20, it would only be for a day at a time, and then all the other residents would know about it. They would throw rose petals on the ground when that resident walked the wards. It was a big deal. But then pandemic hit, and during the COVID pandemic, we had a lot of patients, and the teams were at the cap of 20 day after day after day, and we saw, oh, this is a terrible thing, but we said, gosh, when this pandemic is over, we'll get back to our usual volumes. We didn't. After the pandemic was over, for some reason, so what happened? All right. So what happened during the pandemic was that this hospital and the downtown hospital became a referral hospital for sick patients. So people were being sent here all over the state. If we had a bed, they would transfer a patient from the Eastern Shore Hospital 3 hours away to our hospital. Because beds were so scarce, there was this process in which patients from all over the state could get hospitalized if we had a bed. So when I was on service, for example, we had a patient who was from a hospital 3 hours west of us. This is west of us is in a more mountainous region of Baltimore, and so they flew him here by helicopter. And then when we were getting ready to discharge him, he didn't have a way to get back, so we sent him home on an Uber. That was a long Uber ride, and it was a big bill, but the hospital paid it. But at any rate, this a process of referring us patients from all over the state. If we had an empty bed, it still continues today, and so we were always up against the cap. So we said, well, the resident said, this is it's busy, and it's hard to make each day a good educational experience because the focus was on managing these patients, making sure they got the care they needed, but I think, and well, I know the focus should be on resident education. So we reduced the cap from 20 down to 18. And so the resident says, okay, that's better. Each intern had a cap of 9, and that was better. But still, it was hard to prioritize education throughout the day. And so then we reduced the cap to 16, and that's where we are now. And I think we're trying to hit this fine point in which you get enough education, you get enough clinical substrate to stimulate and inform your education. You need to have the clinical experience. You also need to have a good, robust teaching experience. And it seems like with 16 that we sort of hit that magic point. And so you'll say, that's nice. What about these patients now who are not being seen by the resident teams? There's 4 patients on the purple team, 4 patients on the gold team that now they don't have residents. What happened to them? Well, so the hospital created a new hospice service, and this is a non-teaching hospice service, and they manage these patients who are not on the teaching teams. Now, it's creating a brand new hospice service there's a cost involved there. And what happens is a hospitalist works 7 days on, and then there's 7 days off. So you need to hire 2 hospitalists to create a non-teaching hospice service. So the hospital committed the funds to creating this non-teaching hospice service so that we can have um, reduced caps on our resident teaching services. Now, so this non-teaching service, they've also become busy. They run a service about 15 patients, non-teaching patients, and so the hospital is pretty full all the time, but it's not at the expense of our residents. Now, the night float admits a total of 5 patients at night, and then in the morning, these patients are transferred to the day services. Now, when I first got here, and this look, I've been here 11 years now. When I first got here, the night float cap was 10, and I said to myself, "Oh gosh, that seems like a lot of patients to be admitting at night, especially since they're also cross-covering the teaching service." And so I said to the residents, "Oh, gee, why don't we reduce the night float cap from 10 to 5?" And the residents said, "What do you think the residents said?" They refused. No, they didn't refuse. They were happy. But who do you have to convince? You don't have to convince the residents. You had to convince the hospitalist, because the hospitalists are the people who admit the patients at night, and they're the ones who would admit the patients if the residents don't admit them. Now, let me tell you about hospitalists. Hospitalists all over the country, they're all held to the same standards, the same metrics. What are those metrics? Hospitalists are measured by their work RVUs, their length of stay, their rates of readmission, their patient satisfaction scores. It's the same all over the country. Why is that? Because that's how Medicare reimburses inpatient care. It's a long story, but that's so because Medicare pays the bills all over the country. Hospitalists are subject to the same pressures all over the country. So if I said to I said to the hospitalists when I got here, I said, "Hey, can you guys take the work up the other patients that the night float team doesn't admit, and we're going to cut their caps down to 5." Well, if I had said that to the hospitalists at the hospital where I came from, they would have laughed. They would have said, "Forget it. Are you kidding?" But when I came here, it was a refreshing breath of fresh air. They said, "That sounds like a good idea. We'll do it." So I said, "What's going on here? Are our hospitalists subject to a different set of metrics, different set of incentives?" No, it's the same as everywhere in the country. What was different, though, was the hospitalists here, almost all of them were former residents of this program. Almost all of them were former chief residents of this program. This was their program. This is their legacy. They want to see the program succeed. They want to see the residents do well. And so that was really a refreshing perspective that I was pleased to find, a very supportive hospitalist program, because at the end of the day, in many hospitals, the hospitalist program and the residency program, they're different types of programs. The residency program is, at the end of the day, it's a educational enterprise. A hospitalist program is a clinical enterprise with clinical metrics, clinical outcomes, and clinical priorities. Okay, so the 3 ward teams take turn being on long call. The teams have either Saturday or Sunday off, so they all get 1 day off a week. There's a transitional year intern each month who works on the wards Friday through Sunday. That's their schedule. They work on the wards Friday through Sunday, and they provide cross coverage so the ward teams can have some days off. That intern works in the ICU on Fridays and then on the wards on Saturday and Sunday, providing cross coverage. And then they have Monday and Tuesday off. We have a weekly schedule that consists of 13 blocks. Each block is 4 weeks long. Now, that's also a new thing. We used to just switch on the month, and it would be a month by month, and we'd have 12 blocks. And one of the residents said, "Hey, why don't we switch to a 13 block schedule?" And so I said, "Okay, well, if you can mock it up, then we'll do it." So they mocked it up. They showed how we could adjust to it, and so we did. And we've been now into it for 2.5 years, and it's worked out well. Yeah, but certainly that was much beyond my level expertise to figure out how to convert from a month 12 block schedule to a 13 block schedule. Okay, so here's the weekly schedule from 7 to 7:30. Generally, they take sign out from the night float. On Tuesday mornings, there's a case conference where one of the residents presents an interesting case. From 7:30 to 9, there's pre-rounds. Not exactly sure what happens then. I see the residents walking around drinking coffee. From 9 to about 11, there's attending rounds. And then there's noon conference every day. Now, noon conference on Thursdays, it's either grand rounds or M&M. And then the sign-out rounds at about 4. So here's the schedule for the first-year residents. There's 4 months of wards. No, so they're not months. I apologize. There's 4 rotations. Each rotation is 4 weeks long. There's 4 rotations on the wards. One block on night float, 2 blocks ICU. Our ICU is the ICU CCU combined unit. 1 block of endocrinology, 1 block of emergency medicine. There's an ambulatory block. There's 2 electives and 1 vacation. So all the residents get 4 weeks of vacation. Now, we have a transitional year program here. The transitional years have they're here for 1 year, and then they go on and do something silly like radiology or anesthesiology or ophthalmology, and we have 10 transitional year residents. So almost the same number of transitional year interns as the categorical internal medicine residents. So this is their schedule. Now notice it's not exactly the same. They have a block of general surgery, which is a requirement for them. They have this cross coverage block, as I mentioned before. They help with coverage on the weekend. But for the most part, we try to make their schedule almost the same as the internal medicine schedule. We try to make the amount of call, the amount of clinical responsibility, to try to make it relatively equal. And we don't want it to feel like we have a group of transitional year interns and then we have a group of categorical internal medicine interns. We see it as one inclusive, integrated internship class of 19 interns, and they all work together in a harmonious way. Now, there was a time when the general surgery rotation was based at the downtown campus, and they were assigned to be a general surgery intern, and it was a busy month, and they were on call, and they would help cover the general surgery wards. Um, and but then we decided let's move that rotation up here to Midtown because we're doing a lot of surgeries now up here, and but they don't have a general inpatient surgery service. So that rotation for them has become one in which they're pretty much here during the daytime. They're in the ORs. There's a nice rotation for them. But overall, I think the two schedules are comparable, and I think that groups of residents are very well integrated together. Um, it's a busy year, and if you're working hard and you're pulling your weight, and you want the other people that you're working with, the other members of the team, to be pulling with the same weight, to have the same set of responsibilities, to be scrutinized with the same through the same lens, and so that's what we try to do here. Hey, now watch this animation. Come on, there, you guys like that? I worked on that a long time. All right. So here's a second year schedule, 3.5 blocks on the general medicine wards, a quality improvement block. So that's where you do you work on a quality improvement project. You sketch it out. You don't complete the project, but you get it you get it to the point where you outline it, and then you start to work on it. But this is where you do most of the work in terms of establishing your project. Then at the end of your third year, you have results to show. You present your project, and we have a formal presentation of everyone's quality improvement project. It's really a wonderful day, a day to celebrate the contributions that our residents have made to improving the quality here at our hospital. Neurology is rotation at the downtown campus, and you're on the neurology wards. You also spend half the time on the neurology consult service at the downtown campus. Now, why do we do that? At the downtown campus, they have a neurology department, neurology grand rounds, neurology faculty, neurology residency. It's a and they have some very interesting cases that get referred to them from all over the state. And now I think the transition from a first year to second year is a more challenging transition than from medical student to intern. As an intern, you always have backup, you always have supervision, and that would be your resident. As a second year resident, you're given increased responsibility for managing the patients on your service. You're also responsible for teaching and mentoring the interns and students on the service. You serve as a role model for the interns and students. And you're making the transition from following orders, from managing the patients to deciding what orders to implement, to deciding on a management plan. So it's a challenging transition. Our residents are given a fair amount of autonomy, as much as we think they can handle. They like it, but especially at the beginning of the second year, it can be challenging for them. Here's a third year schedule. 1 block on the general medicine wards, 2 blocks on the ICU, half block of night float. Nephrology outpatient is here. You're in the nephrology clinic. There's a month at the VA, as I mentioned. There's 1 ambulatory block. The hematology oncology rotation is here. It's an inpatient experience. Cardiology is also at the downtown campus, and cardiology is why do we do that? So here at Midtown, we don't do bypass surgery. We don't do angioplasty. We don't do stents. So if you show up in our ED and you have an acute coronary syndrome, we call a Uber for you, send you to the downtown campus. No, we don't call it Uber, but we send you to the downtown campus, and there you'll get your cardiac cath, your stent, your bypass surgery. They have all the interventional cardiology downtown. So to give our residents exposure to interventional cardiology, to acute coronary syndrome, the residents do a month on the cardiology service, inpatient cardiology service at the downtown campus, and they've enjoyed that experience. Okay, now let me say a word about so these are how the rotations line up in terms of the ward blocks for each year. ICU is 2 blocks each year. There's an ambulatory block, and this is an opportunity for you to work in the ambulatory clinic and to get more experience in general internal medicine. The electives are really electives of your choosing, and residents can generally have a range of electives spanning electives here, electives at the downtown campus, electives at Hopkins if they can arrange that, research electives. We want you to be in charge of deciding what electives will work for you in order for you to meet your long-term career goals. Now, let me just say a word about endocrinology, rheumatology, and I think those rotations, you might say, well, gee, you should make those elective rotations. Well, we've required endocrine and rheumatology, and why is that? Because I think to really understand and know those subjects, those 2 specialties, you really got to go to the clinic. It's hard to learn endocrinology and rheumatology by doing the inpatient rotations. Most of the substance, most of the disease presentations, they occur in the outpatient setting. And so to really do justice to learning those two specialties, you've got to go to those clinics. So we've mandated that all residents take endocrinology and rheumatology. Neurology is, as I mentioned, an inpatient rotation at the downtown campus, same as cardiology, and geriatrics is based at the VA. Okay, so here's the Inner Harbor. You can park your boat in the Inner Harbor, visit the sites. The clinic. So the clinic, you have the same clinic all 3 years. The Epic is our EMR for outpatient and inpatient. There's no clinic when you're on the wards, ICU, or night float. But then when you're on non-call rotations, then you have 2 clinic sessions per week. So the total number of clinic sessions over the course of the year is unchanged, but we've sort of condensed them so you get 2 per week when you're on the non-call rotations. You're supervised by general internal medicine faculty in the clinic. We utilize the Yale ambulatory curriculum. There's a short talk that's given at the beginning of each clinic session based on the Yale ambulatory curriculum. If you go through the entire curriculum, you'll cover almost all the topics in general internal medicine. Conferences. So we have conferences every day at noontime. We have these are mostly subspecialty conferences. So the GI gives one conference a month, cardiology does one conference a month, ID does one conference a month, and so forth. We have a case conference on Tuesday mornings at 7 a.m. There's a ambulatory presentation given by the residents rotating an ambulatory block once or twice a month, M&M twice a month, grand rounds twice a month, and then journal club once a month. This is the sim lab at the downtown campus. We have have we had we had a simulation curriculum that was very active that we were implementing. It was before COVID. Then during COVID, the sim lab shut down, and then after COVID, then here at Midtown we have our own sim lab, but it's much smaller. Our sim lab is basically one mannequin in a bed. Here at the downtown campus, they have much more sophisticated equipment. At the downtown campus, is the shock trauma surgeons use this sim lab for their sim training. We have this is the ultrasound machine in the ICU. The machine, not the guy. The guy thinks he's an ultrasound machine, but he's not an ultrasound machine. He's just one of our former residents. We have our residents can use this ultrasound device. We also bought two smaller handheld ultrasound devices for the medical floors, and the residents. It's solely for the use of residents, and residents can use that. And then there's another new ultrasound device like this one that's pictured here in our ED. All right, well, we're not a fellow-dominated program. We do have fellows here in our ICU. They are critical care fellows, and they work with our pulmonary critical care faculty. We also have a ID fellow who works with the ID faculty, helping with consults. But for the most part, we don't have fellows running the consult services. If you call for a cardiology consult, you'll talk directly to the cardiologist. When you call for nephrology consult, you talk directly to the nephrologist. You'll get to know all the subspecialists very well. It's a small hospital. They get to know you, I think that there is a role for the fellows. I know that the residents like working with the critical care fellows, and at the end of each year at graduation, they give an award to the one critical care fellow that they enjoyed working with over the course of the year. The fellows will help our residents with management of hands-on management with the ventilators, with doing procedures. So they provide a great service in the ICU. So we're not a medical school, but we have medical students here. We have students from University of Maryland School of Medicine. We have students from American University of Antigua. We're going to bring on some medical students from Saba University. And our purpose of having students here is because it serves the residents. It serves the residents. We want every resident to have one student to supervise, to manage, to mentor. We think that makes you a better resident. There were months in the past where a team did not have medical students, and the nature of the rounds, the flavor of the discussion, it was different. They were more focused on management, and so I think it's very important for all services to have medical students. The medical students contribute immeasurably to the culture of education of the hospital. But we don't have to oversee a medical school, which is a lot of work. There's no interest in bringing a medical school here. The students from University of Maryland come up here. We don't have on-site research labs here, and there's no intent to bring research labs up here. The labs will continue to be housed at the downtown clinic, especially since they built this brand new research center. Now, some of our residents have availed themselves of research opportunities at the downtown campus. There's their Institute for Human Virology is a lot of great research gets done there, and we've had residents interested in infectious diseases work in that lab. We've had residents work in a basic science lab in cardiology. These are based at the downtown campus. We don't do bypass surgery here. We don't do transplants. So no bone marrow transplants, no kidney transplants, no liver transplants. If those are your areas of interest, this may not be the right program for you. We don't have subspecialists in every field. What do I mean by that? So we have gastroenterologists, but we don't have pancreatologist, duodenologist. No, they do have these. They do have these hepatologists, but they work at the downtown campus, basically on the liver transplant service. The University of Maryland is one of the largest liver transplant centers in the country. They have a really wonderful hepatology group. But so if that's your interest, if you want to work with them and learn from them, you can do that rotation at the downtown campus. But that population and those subspecialists won't be located at Midtown. Same thing with cardiologists. We have general cardiologists here, but at the downtown site, they have heart failure specialists. And basically, these folks are also help manage the transplant patients, the patients with extreme heart failure on LVADs, on balloon pumps. Again, that technology is not here, and those subspecialists are not here. And you can take rotations with them at the downtown site if that's your interest. What's unique? So this program is it's the only program that's sponsored by the institution. We don't have the internal medicine program and the transitional year program are the only two programs sponsored by the institution. The institution is very proud of them. This program has been here for over 70 years, has a strong legacy, and the hospital wants to see the programs do well, wants to see the residents do well. My philosophy is that I want this to be a resident-run program. It's not. I don't think it's any fun if the expectation is that I drive the bus. I'd rather be sitting in the back of the bus, let the residents drive the bus and take us forward. So what does that mean? That means that we want the residents to think of ideas, think of initiatives, think of what they want to pursue. So, for example, we had a resident interested in simulation, and he created that simulation curriculum. And every month we had residents going down to the sim lab at the downtown campus, utilizing the sim lab. In fact, the director of the sim lab said that our residents used it to a greater extent than the internal medicine residency at the downtown campus. We had another resident interested in ultrasound. So they created an ultrasound curriculum. Unfortunately, that curriculum got derailed by the pandemic. We couldn't meet together to teach point of care ultrasound. And then that resident graduated, and then so we haven't had the. We still have a curriculum, but it's not. It's mostly a series of workshops that we have as part of our new conference series. There's a lot of other initiatives that residents have wanted to pursue, and we try to make that happen. We want that to be a hallmark of our program, that residents who have interests, who have initiative, who have motivation, that we want them to be able to pursue it, and we can, it'll make our program better. If they rely on me, I don't know anything about ultrasound. I don't know anything about simulation, and so that's an exercise in failure. to depend on me to come up with those initiatives. So we want our residents to feel like that they can make a difference here, and they should make a difference here, and that by the time they graduate, that they will somehow left the residency program in a better place, that somehow they'll have left the institution in a better place. And that should be a aspiration that you should bring in all your work that you do, that as you go on in your career, that no matter what organization you belong to, that you are going to make that organization better, and you're going to leave it in a better place than it was when you first started. Okay, every program that you go to, look at the balance between education and service. We think that our residents are here for a educational experience. They're not here to be service workers for the hospitals. If you go right now and take all the residents out of the hospital would still function. We have critical care intensivists. We have hospitalists. Things. The hospital would still work, but not. It wouldn't be as fun, and that's why we have residents here. People enjoy having the residents here and enjoy the educational experience. All right. Sometimes we're asked the question, what do we look for in a candidate? So these are some qualities that we look for. Applicants who have initiative, intellectual curiosity, self-discipline, self-motivation, resourcefulness, drive, teamwork, these are sort of abstract concepts, and you'll wonder, well, how does that work? So I'll give you an example. So we had a resident who was interested in. He came here and he said I thought he had interest in critical care. He did the ICU rotations. He really loved it. He talked with the critical care faculty. They said, hey, why don't you do a rotation at the downtown campus on interventional pulmonology? He did that. He also started working on some research projects. And then when it came time to do his quality improvement project, he picked the quality improvement project in the area of sepsis. And because our hospital's compliance with the sepsis bundle was not where it should be, and he did great work in improving our compliance with the sepsis pathway. He improved also some of our relationships with the fellows and with the faculty in terms of our rotation for all of our residents. And so then, he ended up matching to a very competitive pulmonary critical care fellowship. And that's sort of the story. That's his story, and that's his path. Every resident has a path. We don't feel like it's our job to push people or guide people down certain paths. They have to find the path themselves, and then what we think our job is to open doors, to give them the resources for them to succeed. But in order for this approach to work, the residents are the ones who have to have that initiative themselves, have that discipline and the motivation themselves, and the drive and the passion, and if they have that, then we will try to help them. Okay. After you graduate the residency, you have options available to you. You can go into practice as a hospitalist in general medicine. You can go to fellowship. You can go to academic medicine. What have residents done in the past? So this is just the past 5 years. Here we have in the class of 2019, we have someone go to ID fellowship, someone go to nephrology fellowship, one person went to crit care fellowship, one to cardiology, one to sleep, one to GI, and then one practicing general medicine in California. In 2020, we had 4 people go into cardiology. Do we need this many cardiologists in this country? I don't know. We got one person go to pulm crit, one person go to endocrine, 2 go to GI, and one went to hospitalist medicine in Massachusetts. 2021, one person go to cardiology, one to ID, one to endocrine, one to sleep medicine, one to GI, 3 people in primary care, and then one into hospitalist medicine. This was a banner year. Because I do primary care. I like primary care, and I'm glad that we were finally get some folks into primary care. In 2022, we had one person nephrology, one person to cardiology, one to endocrine, one to pulm crit, one to GI, and then 4 people into hospitalist medicine. In 2023, 2 people went into this new specialty of vascular medicine. Yeah, it's a new specialty. It's apparently it's becoming popular, becoming more and more popular. There's opportunities for procedures in that specialty. So those people, I kept up with them closely. They both enjoy vascular medicine and both pursuing it with great vigor. Let's see, endocrine, one person did endocrine, one to rheum, one to another person endocrine, 2 hospitalists, 1 primary care. The one who did primary care, she returned to Seoul, Korea, mostly for family reasons, but now she's back in the U.S. 2024, we had another person go to vascular medicine. One did this guy, he went directly to nephrology practice because he did nephrology fellowship before he came to our hospital. 2 people go to endocrine. There's 4 people went to hospitalist medicine, 1 to hepatology fellowship, and 1 to primary care. And then 2025, 1 to cardiology, 2 to GI, 1 to pulm crit, 4 to hospitalist medicine, and 1 to primary care. So overall, this is over the past 11 years. This is how things have lined up. Our interest is not that people go to hospitalist medicine or to primary care or to subspecialty fellowship. Our primary goal is that people identify a professional goal and aspiration, and then we will try to help them reach that goal. But we don't have a particular number in mind. We don't have a particular goal in mind for each resident. Okay. Hang in there. We're almost done. Baltimore. All right. So this Inner Harbor area is a very festive area, especially in the summer. A lot of activities in the Inner Harbor. The Orioles are a baseball team. They're about a mile away from our hospital. It's a great stadium. Baseball there, it's hit or miss. The previous year they really had a good year. This year, not so good. But it's not hard to get a ticket. It's a nice ballpark. The Ravens are our football team. They're a good football team. If you're not a Ravens fan, we're going to make you a Ravens fan. And you heard it here. They're going to be in the Super Bowl this year. The crab is the food of Baltimore. They're not easy to eat. You need special instruments. We have a simulation lab for this. This is the Baltimore Museum of Art. It's a nice art museum. It's just it's about 4 miles north of us. Residents, they do a lot of things outside the hospital, but it seems to involve eating. Sorry, so here we have a soccer team. Right? We compete against the other residencies in town. And here these guys are. They're supposed to be playing soccer. I don't see them playing a lot of soccer right here in this picture. And then this is another gathering at someone's house. This is the ICU. Doesn't look like a lot of critical care is being provided here. It looks like they're doing a lot of eating. There's some outings that they go on. This over here on the right, that does not look safe. But fortunately, she survived and able to return to the hospital the next day. So this is our soccer team. As you can see, they're holding this trophy. They did not win the trophy. We did not win. They borrowed the trophy and took a picture. But you got to admit, we had the best shirts. It says Midtown United. We have to play these teams where the residency programs are like University of Maryland, 140 residents. Hopkins has 150 residents, and we have 37 residents. But we gave it a shot, and I think we had the best T-shirts, and we had the best baby. See the baby in the middle of the picture. Here's our team. This was a couple years ago. They also didn't win, but this is a nice T-shirt. Also, you got to admit, right? Jeopardy competition. So the Jeopardy competition is we compete against the other teams in Maryland, and this team they won, so they went to the nationals. This is another team that won, and they went to the nationals. And then last year, our team won, and they went to the nationals. So it's pretty cool that our team can win the Maryland competition, and then we can then compete at the national level with people around the country. Okay, so yeah, there are some social gatherings. The residents enjoy. I think they enjoy eating. But they're a very sociable bunch. Okay, so so that's it. You'll have interviews with faculty. You can attend new conference with the residents. There's a virtual tour video that was made by one of our chief residents. Please have a look at that. We have informal, but the most important part of all of this, more important than the interviews, there's a session with residents. And at that session with residents, it's just residents. There's nobody from the program there, and nothing that you say or do will come back to the program. So you can be aggressive, you can be forthcoming, you can be challenging with questions, and we want you to cut open the underbelly of the program and see if this is the right program for you. Our residency coordinator, Katie Bender, will talk to you about the benefits. And finally, I just need to say that routine follow-up correspondence, like saying thank you, it's not encouraged, not necessary. And this is something that was, in fact, discouraged by the NRMP. They don't want programs corresponding on routine basis with applicants, and they don't want applicants to feel like they are obliged to correspond on a routine basis with programs, meaning saying thank you, enjoy the visit, or enjoy the interview. It's really not necessary to do all that. What the reason why that policy exists, is the potential exists to get into some disingenuous communication between the applicant and the program. It's just easy as so you may not hear much from us. That doesn't mean that we don't love your application. Okay, so in finishing, welcome to the Midtown Campus. It was originally an independent community hospital, but it's now transitioned to become an integral component of a large academic medical center with 2 campuses. Thank you for your attention. Thanks for hanging in there. Look forward to meeting with you all individually. Thanks. Bye.